All right, so we're moving right on along, and we are going to start talking about oncologic emergencies. And at the end of the PowerPoint, we'll talk about Hodgkin's and non-Hodgkin's lymphoma. And once again, Hodgkin's and non-Hodgkin's lymphoma are just another type of cancer. So treatment is going to be the same with all the other types of cancers we've talked about. It's much more important to me that you know what is present in Hodgkin's versus non-Hodgkin's. So how do they present? Like, how do you know a patient has Hodgkin's versus they have non-Hodgkin's? So that's where your diagnostic studies come into play. So we're looking at basically the complications or the emergencies that can happen specifically with cancer types of patients. So this is a pretty straightforward slide. I think most of the stuff in here is familiar to you. You do know about bleeding and hemorrhaging already. You know that you need your platelets for normal blood clotting. You're clear about this. You know it. You know what thrombocytopenia is. You know that the platelet count can vary, and you know what the normal platelet count is, and you also know that when it starts being like 50,000 or less, that becomes really dangerous to the patient, and they can end up having central nervous system manifestations, right? We've discussed all of this under some other different types of slides. And you know that bleeding is very common in cancer patients. So what are you going to do for bleeding? We've talked about this in shock as well. So it's always the same thing, right? Fluids, blood, basically, like that's pretty much what you're doing over here. So blood, fluids, FFPs, if that's what's primarily needed. Okay, so easy slide. Sepsis, septic shock, we also kind of touched on a while back. I think this is in chapter 14. So you know that here specifically there's bacteria that's involved. So it's gone into the blood and it's produced septicemia. And the biggest issue is that it can lead to multi-system failure, right? And so some of the signs and symptoms you're very familiar with already. So high temperature, peripheral edema, hypotension, tachycardia, anxiety, and restlessness. And the big deal with sepsis, septic shock is that we want to identify actually sepsis when the patient is in the hospital as quickly as possible. So we do have sepsis bundles that they have like at each institution where they really want you to monitor the patient so you can get a handle on this very quickly, because if you don't, then you're going to end up with things like decreased urinary output, more hypotension, like or worse hypotension, cold clammy skin, and altered mentation. So you know that this bacteria is involved. So for sure, you know that in terms of your treatment, they treat this very aggressively. So some of the things they do, they right away, if it's sepsis, septic shock, it's vasopressors. Right away, things like norepinephrine, fluids, mechanical ventilation for sure to give oxygen, antibiotics, all of those types of things. And you want to catch it as early as you can because it has a very poor prognosis. You don't need to memorize what the triples are, but just know some of the treatments. So vasopressors, fluids, O2, mechanical ventilation, antibiotics. So it's a very aggressive treatment that's going on. With hypercalcemia, this is boring as well. You know what hypercalcemia is. So here, just specific for cancer, this can happen. That's the main thing. So calcium is released from the bone is more than the kidneys can excrete or the bones can reabsorb. So you end up with this high serum calcium level. So some of the cancers that are especially known for this, breast cancer, lung cancer, thyroid, and esophagus cancers. Bone metastases for sure can cause things like hypercalcemia. So what are your signs and symptoms of hypercalcemia? You have a slide already from chapter 15, I think, that talks about, your electrolytes. All right, so what is your treatment going to look like? So boring. So calcitonin, which decreases your blood calcium level, hydration for sure, and depending on the situation, the patient may even need things like hemodialysis. So for your purposes, you want to know your lab values, okay? There is this special thing known as a tumor lysis syndrome. So this is a life-threatening emergency. It's characterized by combination of two or more metabolic abnormalities. So your previous slide had hypophosphatemia, and that was incorrect. So I fixed it. So it should be everything is hyperuricemia, hyperkalemia, and hyperphosphatemia. And the issue with the patient having the hyperphosphatemia is that they're going to end up with hypocalcemia, right? So that's a lot of funky things going on. Main takeaway is that you're getting an electrolyte imbalance. This is how it manifests. And so you're getting what? Symptoms, neurologic, cardiac, GI, and renal issues. So think of all of these things: hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia. So how is that going to manifest in your body? And these are things that you should be familiar with, because we've talked about all of this, whether under kidneys. Yeah, okay. So you want to prevent kidney failure and restore fluid and electrolyte balance. So what does your treatment look like? So I've adjusted a few things here, but release hydration, diuresis if needed, if the urinary output is not sufficient. You're giving phosphate binding agents or aluminum hydroxide to treat any high phosphate levels, and things like hemodialysis if that is needed. Yeah, so some of your the weird issues that can happen are that the patient can even end up having things like seizures also. So that would not be good. There is a chart in your book at page, I think it's 383, that has all the oncologic emergencies spelled out. So you want to look at that as well. There's this thing known as superior vena cava syndrome that can happen. So I've adjusted that first point. So it's compression or invasion of the superior vena cava by tumors, enlarged lymph nodes, intraluminal thrombus that obstructs the venous circulation, and then you end up with a whole bunch of issues basically, right? So think of your superior vena cava, where it's coming from and where it's trying to go. So if it gets obstructed, if there's cancer in there, there's a thrombus or whatever, then what is going to happen, right? What is going to happen to all that blood that's supposed to be going somewhere, but now it can't do that? So just follow your blood. You've done 313, so you know the passage of blood, right? So key thing here is you're getting obstruction and backup of blood flowing into the superior vena cava, okay? So we can get things like facial periorbital edema. Then later on, you're going to be getting things like dyspnea, altered consciousness, and respiratory distress. So edema of the face, arms, and hands. So this is a picture of how the patient may present. Right, so everything is pretty engorged. Some of your emergency measures. So for sure, you're going to do respiratory support. You're monitoring vital signs, administering corticosteroids if there's inflammation there. If due to a clot, so whatever the cause is, if there's a thrombus, then we need to take that clot out, right? So we're going to give things like thrombolytics, essentially, or if we need to bypass the clot, maybe we can't get it out, then maybe we're going to put in a stent or something and bypass it. So you try to find out what's causing it. You are providing a safe environment. Obviously, if it's caused by, maybe it's cancer or something that's there, then you're going to do things like radiation to shrink the tumor, things like chemotherapy, right? So key thing is trying to figure out what is causing it, and then you're basically targeting that. All right, this slide has select cancers. So there is another, I thought I'd put it on there, but maybe I didn't. There is another oncologic emergency that is known as, let me see, your book has spinal cord compression, right? So spinal cord compression is also on your chart, so I don't go into that at all because we've done spinal cord injuries already, but just know that spinal cord compression can also happen. So then what types of treatment do we need to do for that? So it's the same things we'll do under spinal cord injuries. So whether it's giving steroids, whether it's doing surgery to relieve the compression, that's just the normal thing. So just know that spinal cord compression can also happen, and that would probably happen most likely if there's a tumor there that's compressing that as well. All right, so now we have lymphomas, and so they are malignancies of the lymphoid tissue, and they're characterized by proliferation of lymphocytes, monocytes, and macrophages. So keywords proliferation. And remember, they're not good. There's too much of them, but they're not the healthy, strong ones that we want. Some of them are dying off anyway, rapidly proliferating, and then also dying off at the same time. So this is not a good situation. So specifically, we're talking about Hodgkin's lymphoma and non-Hodgkin's lymphoma. And they're classified according to the degree of cell differentiation and the origin of the predominant malignant cells. So they can start in the lymph nodes, but can involve lymphoid tissue in the spleen, GI tract, liver, and bone marrow. So they can essentially metastasize. So Hodgkin's lymphoma has a high cure rate, relatively rare malignancy, apparently more common in men than women. I don't need you to memorize gender issues at all. Has 2 peaks of incidence, early 20s and after the age of 50. Your book may cite 55 as the main age. Unfortunately, it can also be seen in patients who are receiving immunosuppressive therapy. So maybe patients had a different type of cancer and they were getting immunosuppressive therapy, and now they end up with Hodgkin's lymphoma. That could be one situation. And any veterans of the military who were exposed to herbicide Agent Orange. So that was an agent that was, made to kill us, right? Made to kill people. So that definitely suppressed the immune system, and they ended up with things like cancer. So those are just examples, and there is a familial pattern in some patients. So that's what I'm talking about in terms of knowing how this one is different from the other one. So you want to know that it develops in a single node. They'll call that unicentric, and then it spreads to adjoining nodes. It has the potential to do that. So it involves the lymph nodes. It contains the Reed-Sternberg cells. That's the malignant cell. So you have to be able to tell me in Hodgkin's lymphoma what's the name of the cells that it has. So it has a Reed-Sternberg cell. That's what differentiates it. So they invade almost any tissue in the body. Spleen can be involved as the disease progresses. The liver, lungs, digestive tract, and CNS may also be affected. All right. So single node, keyword, unicentric, and Reed-Sternberg cells. Okay. The manifestations matter as well. So how does Hodgkin's lymphoma present itself? So it's a painless enlargement of one or more lymph nodes on one side of the neck. So keyword is painless and then enlargement. So it could be one or more lymph nodes. So common sites, cervical, supraclavicular, mediastinal nodes. Pruritus is also common with Hodgkin's lymphoma. All organs are vulnerable to invasion of tumor cells, and the symptoms result from compression of organs basically by the tumor. But I mean, a tumor is invading your host, so it's just cancer again, right? Herpes zoster infections are common as well. All right, so Hodgkin's lymphoma example here. Hodgkin's lymphoma example here, neck lump caused by swollen lymph nodes. Okay, very distinctive. The client may exhibit a cluster of symptoms, so I do need you to be familiar with the symptoms and what they're called. So they're known as the B symptoms. So the patient can have things like fever without chills. They can have drenching sweats. They call them drenching night sweats. They happen mostly at night. The patient has an unintentional weight loss, more than 10%. Apparently, these symptoms are found in more than 40% of patients, and anemia is the most common hematologic finding. All right, so in terms of your findings, so they're going to be all over the place. We've discussed this already, how this might be possible in cancer, right? So leukocytes may be increased or decreased. Erythrocyte sedimentation rate elevated, just letting you know that there's an inflammatory response going on. You are going to do a lymph node biopsy specifically, and you're going to be looking for Reed-Sternberg cell. So things like chest x-rays, CAT scans of the chest, abdomen, CBC, platelet count, liver, renal function. You are going to be monitoring all of that. Your platelets could be normal unless the tumor has invaded the bone marrow, and then you end up in trouble. All right. So just know that basically your blood levels are pretty much all over the place. Treatment is determined by the stage of the disease, so that means it's going to be variable. So it could be a short course, 2 to 4 months of chemotherapy, followed by radiation therapy, or it could be combination therapy, meaning that they're doing both of those things. And then here you are just being given some of the medications that can potentially be used. And then you are doing all the usual standards of treatment that goes with cancer. Of course, the goal is always to cure it if you can, or at least make the cancer go in remission, because some of these things are really not curable at all. So the treatment is based on the stage. So either it's chemo, radiation, or both, right? So whatever needs to happen. So clients are prone to secondary malignancy. So depending on the treatment they're getting, so let's say they're getting radiation, well, that puts them more at risk for getting other types of cancers. So because of the treatment they're getting, whether it's chemo or radiation, they're basically more at risk for other types of cancer. So you want to reduce factors that increase the risk of developing secondary cancers. So if your patient is smoking, drinking, exposed to environmental carcinogens, going outside, you want to tell them not to do that. So in terms of nursing, just like any other type of cancer, the patient is fatigued, right? They are worried about, having this death sentence. Their mental emotions, they're just all like really, really all over the place. They're scared. So you just have to aggressively make sure that you are watching your patient carefully. Your non-Hodgkin's lymphomas. So these ones do not contain the Reed-Sternberg cells. All right, so they do not contain Reed-Sternberg cells, key, and then they tend to start in the peripheral lymph nodes and spread early to tissues throughout the body. Non-Hodgkin's, more common non-Hodgkin's. Older adults more affected, apparently more men than in women, and obviously nobody's 100% sure what is going on with it. The spread of the disease apparently is unpredictable, and you rarely get just the localized disease manifestation. So it tends to spread, and the way it spreads, they're saying, is very unpredictable how it does it. So it can start as a single transformed cell, may arise from T cells or the B cells, and then it basically spreads early and in very unpredictable to other lymphoid tissues and organs. Prognosis ranges from excellent to poor, and then obviously the bigger the tumors are, the more aggressive they can be, and they have a poorer prognosis. All right, so example there. Another picture. Okay. Your clinical manifestations similar to Hodgkin's disease, so nothing different there. So painless lymphadenopathy, localized or widespread in some patients. So B symptoms may be seen. B symptoms are more so in the Hodgkin's lymphoma. It's what the literature is saying, but in maybe a third of the patients with non-Hodgkin's, they may also have B symptoms. Organ involvement, abdominal pain, nausea, vomiting goes without saying. This is cancer after all. Okay. So treatment is determined by the classification of the disease, and that makes sense. So just examples here of some of the chemotherapy medications that they can be given. We already know about chemotherapy at this point. We've talked about it and how that may manifest. And so the nursing care, nursing assessment, like I said before, is the same. This is just a different type of cancer. That's it.